Welcome to Chapter 1, in which we will discuss the need for quality in EMS. When completed with this module, you should be able to identify the need for quality improvement, recognize the current status of medical errors, engage in quality activities and offer quality initiatives, analyze the current state of medicine and issues in quality, locate and identify the source of current medical errors information, and compare and contrast the need for quality. To begin this chapter, consider the following scenario. You are an ambulance company operations supervisor and you just received a letter from a local medical center with a comprehensive cardiac program. According to the letter, the outreach coordinator for the cardiac care program stated that your paramedics were administering aspirin in only 54% of the STEMI cases where it was indicated. Based upon that feedback, your Quality Improvement Committee suggested that the aspirin and nitroglycerin bottles be held together with a rubber band to serve as a subtle reminder to administer aspirin along with the nitroglycerin. Within 1 month of full implementation, your service's compliance percentage rose from the aforementioned 54% to 95%. With this scenario in mind, how does it reflect the growing movement toward quality? What makes this a cost-effective solution that relates to a national standard of care? What type of error or classification does this incident appear to be? Do not worry if you cannot answer these questions quite yet. By the end of this module, you will be able to answer them authoritatively. The term quality is used all the time in association with both products and services. Well-known companies such as Mercedes, Disney, Apple, Ritz-Carlton, and others pride themselves on producing high-quality goods, experiences, or services. This concept of quality ties into customer perceptions. When one goes to a local fast food restaurant to eat, the expectation is probably very different than if the same person walked into a 5-star restaurant for an expensive dining experience. Driving a BMW involves a very different expectation compared to a Kia. In many cases, this expectation also correlates with the cost of the good or service. That BMW costs a lot more than a similar Kia, and you could probably eat at McDonald's, Burger King, Taco Bell, or any other fast food restaurant for days on end with the money spent for a single meal at the elaborate steak place in downtown Chicago. Quality often comes at a cost to the consumer. With that being said, there are also some industries in which quality is implied by the very nature of the goods or services provided. Healthcare is one such industry as people expect high quality at all times from their healthcare providers, and EMS is no exception. Despite this expectation of quality, however, EMS as a profession has historically not focused on quality, as few initiatives seem to exist within the field of pre-hospital medicine. This is where things become somewhat interesting. While EMS providers may have the desire to deliver the best care possible, EMS personnel typically have less training, education, and supervision than other healthcare providers, such as physicians and nurses. Despite this disparity, the public still expects high-quality care from EMS providers akin to that which they would receive in a hospital setting. The nexus of this sense of duty, public expectations, and limited training actually fuels the need for heightened quality within EMS. The current expectation of various medical disciplines, EMS included, is that quality initiatives are in place to improve the patient experience and outcomes. In this respect, quality of healthcare has been defined by the Institute of Medicine as the degree to which health services for individuals and patient populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Notice the two components of that definition. Not only do EMS providers need to look at patient outcome data, but it is also incumbent upon them to remain current on the practice of emergency medicine. In this respect, continuing education for EMS providers is obviously very important. In seeking to improve quality in emergency medicine, EMS agencies must strive to increase the effectiveness and efficiency of its processes. Given the need to not only review data but also include current and emerging practices within its standard operating protocols, this also means keeping a watchful eye on emerging research in the field of emergency medicine. In reviewing data and emerging research, there are times in which a gap in quality may be observed. Formally, a quality gap is defined as the difference between the processes and outcomes observed in practice and those thought to be achievable with the most current and effective professional knowledge. One example of a quality gap would be the availability of portable medical diagnostic and imaging tools. While EMS is not quite at the point where every ambulance has an MRI, advances in ultrasound technology, for example, could have a profound impact on the diagnosis and treatment of numerous ailments that were previously not diagnosable in the field. The goal of an effective quality improvement program is therefore to identify quality gaps and minimize or eliminate them as possible or feasible. Another important definition within the realm of EMS quality improvement is that of patient safety, which is the absence of the potential or an occurrence of a healthcare system injury to a patient. As denoted in the textbook, quality improvement seeks to improve outcomes in general. Patient safety is more specific, as it is possible for a patient to still have a positive outcome despite an error in the care provided. As the likelihood of a bad outcome is increased by medical errors and missed opportunities, any move to quality by an EMS agency's quality improvement program must also recognize the underlying need to maintain and improve patient safety wherever and whenever possible. Despite the obvious benefits of providing high-quality patient care through aggressive care and the reduction of errors, there is also a very real push to increase outcomes by the organizations that control the system's proverbial purse strings. Insurance companies and accountable care organizations are starting to look at medical care on a more holistic level with a focus on patient outcomes. Previous fee-for-service models are starting to be replaced with other outcomes-based funding models that reward quality. Even Medicare and Medicaid are talking about transitioning from a fee-for-service model to one of value-based reimbursement. In such an environment, quality takes on an even greater importance as it is tied directly to financial reimbursement. For another perspective on the importance of quality in EMS, several documents have been produced over a period of time, going back to 1999, that have been critical of EMS and its lack of a concerted focus on quality initiatives. These documents are now considered authoritative on the subject and have been known to have an impact on legislative policies and EMS funding. Needless to say, the expectation today is that all EMS agencies have some type of quality improvement process in place. Of the many items identified within those Institute of Medicine documents, the one that probably does the best job of underscoring the need for quality within healthcare in general is that medical errors are considered the 8th leading cause of death for Americans, ranking higher than deaths due to motor vehicle collisions, breast cancer, or AIDS. The information within the To Err is Human document estimates that hospital errors occur in 5 to 10% of all patients admitted into United States hospitals. These arguably preventable medical errors kill anywhere between 44,000 to 98,000 Americans annually. The To Err is Human report was published in 1999, so the statistics provided are somewhat old. At that time, however, the estimated annual cost of medical errors was $37.6 billion, and those figures did not include medical errors that occurred outside the hospital setting. As denoted within the textbook, approximately 1.14 million patient safety incidents, unintended or unexpected incidents that could lead to harm, occurred among the 37 million hospitalizations in the Medicare population over the 3 years of 2000, 2001, and 2002. These patient safety incidents resulted in an increase in medical expenditures, contributed to 90-day death rates, and were associated with increased 90-day readmission rates. As this data focused only on Medicare recipients, it is a fair assumption that the problem is even larger than it seems from those numbers. Thus far, the data we have looks at hospital-based errors only. As a result, we have no idea of the true scope of the medical error problem, as those errors can occur at nursing homes, health clinics, pharmacies, within the patient's homes, and in the back of ambulances. Unfortunately, the Canadian Patient Safety Institute report noted in 2010 that there were no studies available regarding medical error rates in EMS. Surely they occur, but there is no broad general data available to measure the rate at which these errors occur or to determine the impact of such errors on patient health and outcomes, as well as the financial impact of those errors. As mentioned previously, Medicare and Medicaid are beginning the process of shifting from a fee-for-service reimbursement model to a value-based system. As reimbursement in EMS changes as a result, quality improvement initiatives will need to evolve significantly to ensure compliance with these emerging value-based initiatives. Measurable outcomes will someday be required for services to receive reimbursement for healthcare services rendered. With all that being said, one would suspect that most EMS providers would indeed agree that quality is important in EMS. The problem, however, is multifaceted. First, installing and maintaining a quality program has a cost. While it is commonly accepted that a robust quality improvement program will save money in the long run, many EMS managers fail to recognize the value of incurring upfront costs for a quality improvement program to eventually reduce risk, errors, and the costs inevitably associated with them. Another barrier is that EMS has historically done a bad job of training providers, managers, and leaders in the mechanics of conducting quality improvement. As a result, few understand how quality improvement programs work, which ultimately hurts organizational buy-in and sustainability of the initiative. For this reason, few services have a written quality improvement plan, which further impedes the adoption of and internal support for the program. One of the largest problems within EMS as well is that the culture of many organizations do not support quality improvement initiatives. Given excessive hours, low pay, cumulative stress, and other factors, a certain amount of complacency tends to develop. Many experienced providers lose their customer service focus and begin to adopt the close enough is good enough mentality. Many EMS organizations also lack what is known as a just culture, in which managers approach problems as opportunities to learn and improve, with the assumption that the providers involved were not acting with bad will or malicious intent. In a just culture, the assumption is that your providers are making good faith efforts to provide the best care they can. They are trying to do the right things for the right reasons. In such a culture, reporting medical errors and near misses do not automatically have negative or punitive outcomes for the providers. Rather, that information is used to coach and develop the providers while also seeking to reduce or eliminate the likelihood of repeat occurrences of the circumstances that contributed to the potentially bad outcome. Ultimately, healthcare organizations that fail to measure quality and use that data to improve the system are in danger of developing a condition known as normalization of deviance. This phenomenon occurs when an entity becomes so complacent or comfortable that it deviates from the standard of care or practice, thus offering substandard care or assessments that eventually result in poor care, medical errors, and bad patient outcome. A simple example for seasoned EMS veterans would be the frequent flyer patient who calls all the time for help when he or she really does not need it. After the 10th, 20th, or 100th time seeing this same person for the same non-existent problem, it is not unusual for the providers to no longer perform a thorough assessment or even consider the patient's complaints factual. Maybe the crew begins to ignore the patient on subsequent runs while competing to see if they can shave seconds off the previous time it took for the patient to sign a release for the crew. Over time, this behavior is reinforced because there are no negative repercussions to this apparent practice. That is, until one day the patient is actually experiencing a real problem and the crew does not recognize it because they have become complacent with regard to this particular patient. All of those previous interactions with the patient cannot be used as the excuse for failing to properly assess and treat the patient the one time that he or she really needed emergency intervention. While this is obviously a single specific example given a routine occurrence in EMS, the system abuser, some other scenarios are not so blatant or identifiable, and normalization of deviance from the accepted standard can occur so slowly within an organization that you may not even recognize it until it is too late. The causes of this deviance can also be diverse, which can make it even more challenging to identify. Poor leadership, lack of training, overutilization of services, and skill degradation are common culprits. That is yet one more reason why quality improvement programs are so important. Those programs help prevent this normalization of deviance from taking a foothold within the organization. To help with this discussion of quality as it relates to healthcare, it is important to identify the most common causes of medical errors. The first such cause of medical errors includes communication errors. As a simple example, 16 and 60 may sound the same over a radio, yet there is a huge difference between those two numbers when they are used as dosages related to a medication error. Our second source of medical errors relates to the increasing specialization and fragmentation of healthcare. The more hands in the proverbial pot, the more likely a mistake will be made due to the interaction or lack thereof between these numerous healthcare providers within this single patient's care. The third source of medical errors identified within the text should come as no surprise to EMS providers. Human errors due to overwork and burnout are unfortunately common. Within the field of EMS, where providers may work 24-hour shifts, sometimes without the ability to sleep during those periods, provider drowsiness and fatigue is a significant concern that can give rise to medical errors. Manufacturing errors serve as another precursor to medical errors. From a faulty piece of equipment that fails to the mislabeling of medication, manufacturing errors can have deadly consequences. Along somewhat similar lines to manufacturing errors are equipment failures. Whether a piece of equipment fails due to a manufacturing error, inappropriate use in the field, lack of required maintenance, or simply from being used beyond its intended life cycle, the end result can still be catastrophic for the patient. An EMS crew that fails to ensure the batteries are charged in the defib unit, for instance, can lead to a preventable equipment failure when seconds are literally the difference between life and death. Diagnostic errors can be problematic, especially if a patient is incorrectly diagnosed and the treatment for that improper diagnosis is contraindicated for the patient's actual ailment. As a quick example, a paramedic deciding a patient's hypotension is due to dehydration when it is really due to problems with congestive heart failure will not be doing the patient any favors by starting an IV and administering a fluid bolus. Sometimes, numerous options available for treatment of specific ailments can create problems by providing choices when a singular evidence-based approach would be more appropriate. These multiple choices for care provide multiple opportunities for providers to make wrong or inappropriate decisions to treat particular patient ailments. Lastly, environmental features, such as poorly designed vehicles, buildings, and facilities, can result in medical errors as well. In a typical ambulance, the captain's chair in the rear compartment is offset from the patient's head. While this may be more convenient for the provider to use the adjacent shelf as a workspace, it is not helpful when the paramedic needs to intubate or maintain the patient's airway. The lack of a proper design could actually work against the provider and the patient in such a scenario. Within the realm of EMS specifically, the Institute of Medicine's 2006 report, Emergency Medical Services at the Crossroads, recognized some specific medical errors that appear to be more prevalent in EMS. The first is airway adjunct choice and placement. Endotracheal intubation, in particular, is routinely cited as a skill that may not be as vital or effective as previously professed. The study cited by the textbook found that intubation errors occur at rates of anywhere from 22 to 40 out of 100. Errors are more common when the patient is a child under 6 years of age. The data also indicates success rates are higher on services where a smaller number of paramedics are intubating with greater frequency. Medication errors are also suspected to be more prevalent in EMS. Such errors can include simply giving the wrong medication. Incorrect dosages and concentrations can be administered. The wrong route of administration can be used as well. A common example of a routine practice that can lead to errors is the shortcut of dividing the weight of a person in pounds by 2 to approximate kilograms. First of all, the paramedic may guess the patient's weight wrong to begin with. Beyond that, there are 2.2 kilograms per pound. Approximating 2 kilograms per pound results in a cumulative rounding error, if you will, that increases along with the patient's actual or suspected weight. If the dosage of a medication is determined by the patient's weight, using 2 kilograms per pound has the potential of leading to an overdose. At this point, there is no reliable nationwide database for the reporting of EMS medication errors, so no one really knows how often such errors occur. One study cited in the book indicated that almost 1 in 10 paramedics at a single EMS agency admitted to at least one medication error during their career. Depending on the nature of such an error, the impact on the patient's eventual outcome can be significant. The other area of EMS practice in which errors are seemingly more prevalent is in the care and transport of pediatric patients. These errors include diagnostic errors, incorrect procedures or tests, infections, injuries, and, again, medication errors, predominantly due to the fact pediatric dosages are often based on weight, they are not standardized, and providers are expected to perform calculations in the field for the proper dosing of pediatric patients. Pediatric errors are even more troubling considering that pediatric patients are less able to compensate physiologically for improper care. Pediatric patients are also typically unable to advocate for themselves where healthcare is concerned. An astute adult may recognize something is wrong with the care he or she receives, while a child is less likely to recognize errors in care. To wrap up our introduction, medical errors are unfortunately common, and they have significant costs in both money and patient well-being. A quality improvement program strives to recognize medical errors or situations that may give rise to them and reduce or eliminate them for the benefit of everyone involved, the patient in particular. Where continuous quality improvement activities are concerned, having a team involved in the process is commonly preferred, as a team of professionals have a greater likelihood of identifying potential solutions to quality problems. With that being said, however, someone within the organization must be ultimately responsible for quality initiatives, and this person must ensure that any program is data-driven and that implemented improvements are monitored for effectiveness. It is in the best interests of any EMS agency to encourage employees to not only identify potential quality issues, but to also develop potential solutions for them. The key is to not only identify the issue and develop possible solutions, but to also implement those solutions and review their effectiveness over time using data. Going back to the scenario provided at the start of this module, the failure to provide aspirin in accordance with the appropriate protocol was a combination of several medical errors: diagnostic, fragmentation, and communication. A treatment regimen was discounted by the providers, and the appreciation of the diagnoses was not properly communicated. Addressing these factors ultimately made a significant difference in the quality provided by the providers in this scenario. Ultimately, we are past the days where EMS can function without employing some type of continuous quality improvement system to minimize medical errors and enhance patient care and outcomes. As a matter of fact, many states now require EMS agencies to have a continuous quality improvement program in place, and Wisconsin is no different. Wisconsin Administrative Rule DHS 110.47 sub 4 requires every EMS agency in the state to have a quality assurance designee who is responsible for managing patient-based quality improvement processes in collaboration with the service's medical director. DHS 110.49 sub 2E mandates that every EMS agency medical director establish, participate in, and ensure the continuing implementation of a quality assurance program as part of a patient care improvement process. With these legal requirements in mind, EMS agencies must ensure patient safety and quality improvement activities are supported by evidence-based protocols and the continuous measurement of performance. This means using empirical data in continuous quality improvement activities and closing the loop on system improvements through reevaluation to ensure those improvements resulted in the desired outcome. It has been said that you cannot manage what you do not measure. While the applicability of that statement may be open to some debate based upon the context in which the statement was made, it is definitely a valid statement for EMS continuous quality improvement programs. Data is necessary to not only identify problems and trends, but to evaluate program effectiveness and the impact of implemented changes. Hopefully you now have a basic understanding as to what quality means in the healthcare profession and why it is important. In the next module, we'll begin to explore the history of quality as it relates directly to EMS.